Hello, my name is Reagan May. This is my cardiovascular assessment, and this is a video presentation for the cardiovascular and peripheral vascular. So, my wife will pretend as a patient, and she's consenting to have this videotape. Do you consent to have this videotape for educational purposes?
Yes.
Of course, for every patient visit, you need to do your hand washing, introduce yourself, and then you do your patient identifiers. So you start with assessing. Hello,
Hi.
my name is Reagan. I'll be your nurse practitioner, and then we'll do your physical assessment. So we'll do your cardiovascular. First of all, you can ask your patient to lie back, and then we'll start assessing the JVD, the jugular vein distension, and to start, you need to do the vitals, to check the blood pressure and all those other vital signs that's needed. So to check for the JVD, you most likely you stay at the right side of the patient, and you turn the patient to the left, and then look for the turn patient head to the left, and look for the jugular venous pressure. Locate the palpation of the internal jugular vein. And for this patient, somewhere here down, which is a very defined pulsation. So with a straight edge and a ruler, you measure it from the side until the suprasternal notch. So somewhere down here, and then suprasternal notch will be here, so it's around 1.2 centimeters. So the normal GVT would be normal jugular venous pressure would be around less than 3 centimeters. So the next part would be you assess the patient's carotid pulses. So you do not check from the top, you check somewhere on this side, avoid the higher part of the neck. Fill the lower neck with the carotid pulses. And also you can use your stethoscope to listen for your carotid pulse, and when you feel it and you're also listening to it, the upstroke happens right after your S1 and before your S2. So when you listen to your carotid artery for bruit, you use the bell as a high frequency sound. That's perfect. It's a bounding pulse. And also you will listen to your diaphragm. The next part would be the precordium and then cardiac function. So you will start with your inspection of the chest wall, the symmetry of the movement. So we start from the right sternal border and the second intercostal space, which is your aortic valve, and then right beside the mid-sternal border is the pulmonic valve, the second intercostal space. So you do your inspection, and then down 3, 4, 5 is your Erb's point. 4, and then 5, and then right behind your fifth intercostal space is your apical pulse. This is the apex of the heart, or the PMI. For patients who are thin, just like her, you can really appreciate the apical pulse to the surface of the, to the chest wall. The other way to detect your apical pulse is you ask your patient to turn to the side and a lateral recumbent. So you turn to the side, and then you try to bend your patient outward, so at least your heart will be more of a floating side to the chest wall, and then you will feel the pounding of your heart. ask your patient to lie back. So you will also have to auscultate with the diaphragm and then the bell of the sound. So you start from your second intercostal space, your aortic. And your pulmonic. So moving down to your third, fourth, fifth is your Erb's point. Your tricuspid, and then your fifth intercostal space midclavicular line, and then anterior axillary is your aortic. I can hear vowel sounds too. Very perfect. Okay. So for some patients, the split of S1 and S2 are normal, and then this is because of their attitude and they're moving than younger patients, so it's not something contradicting with their health history. The split of the S1 is sometimes the closure of your, the split S2 is sometimes the closure of your pulmonic and then aortic valve is not perfect, it's not together. Okay, that ends the cardiovascular, and then I'll do my the peripheral vascular would be to peripheral vascular is to inspect your abdominal area. So you listen, you inspect, and then you feel for aortic palpation. And then you start from the top of the umbilicus. And then the iliac, and then the renal artery, and then the femoral artery. So for a real patient situation, you ask them to move their trousers downward a little bit, so at least you can expose this side, and then you can inspect and then feel. You also listen for bruit and aortic pulsation, and then you and you check for the renal artery, and then the renal iliac artery, and then the bifurcation of the renal, and then the split of your renal and iliac. Also, for a real patient situation, you ask them to lift their shirt up so you can inspect the skin, or if there's any hernia, or if there's any asymmetrical definition of the skin area. And going down to the lower part of the body, so you do your inspection, and you check for edema, you check for the arterial, you check for dorsalis pedis, and then the Achilles. And checking for the peripheral pulses, you also have to check for the arm, and you check for the radial artery. You feel, you do it on both sides, and then your brachioradialis. And also it's a good good way to check for Holman sign and to rule out DVT. So you ask the patient to lift the leg up, and then there's a flexion of your toe, and then positive Holman sign is when they feel pain or tenderness on the calf muscle. So you do it on the both sides. Check for peripheral, of course. You check for capillary refill, so it should be less than 3 seconds to give peripheral circulation. That ends my assignment for this review. Thank you.